and you thought I was done. Yes, I know. I said that we were wrapped up with the visit to Dr. Cooley's office, but that was just the surgical side of things. I wanted to give you an opportunity to learn more about Dr. Cooley, to get an idea about him as a person by just getting to listen to him talk. And he's talking about his background. You get to understand his motivation for all the research that he does that's led him to bringing out some of the most recent standards in the industry. So without further ado, here's Dr. Jerry Cooley. Enjoy.
I genuinely care. I care about the results. I care about patients being happy with the results. I care about patients understanding their hair loss. I love what I do. I'm obsessed with always trying to become better. I mean, I think putting that all under the category of, I really do care. I mean, I think probably a lot of people in our specialty could say the same thing, but I really love what I do, and I try and bring that into my day-to-day work. I think it started in my residency. How I got started is a little bit unusual and a little bit different from other doctors. I got exposed to hair transplantation as a dermatology resident in Baltimore. And while my surgery professor was teaching me hair transplants, I was also doing some research in the lab, and I was growing hair follicle cells for a project. And it just struck me almost from the start that there would be things from the lab or things from the research area that would be applicable to what's being done to make surgery better. For example, I knew that most doctors put their grafts into saline while they were being stored prior to being placed. Yeah. And to me, I thought, well, we're growing cells in this special media with sugar and vitamins and buffers. Wouldn't it make more sense to put grafts in it? So I got interested in holding solutions. That's really where it started. And I spent many years looking at different things and did some research, and it led to our using the hypothermosol. But that naturally led into other things. How else can we make the procedure better? And taking what I see in my practice, for example, if I don't get the results I expect, what went wrong? And at some point when you get enough surgical experience and you feel like you're doing everything right from a technical point of view, and then you don't get the results you expect, it's something outside of your surgical technique. And that's why looking at holding solutions, looking at growth factors, looking at ways of keeping the grafts viable till they can live on their own. Most doctors, and I think all patients, probably assume that once those grafts are put back in the scalp, they're safe and sound. Yeah. In fact, it takes several days for them to develop their own dedicated blood supply. Right. So that's where the post-op ATP spray that I worked on came about. So yeah, and I still believe that there's a lot of untapped potential. There's a lot of things going on in regenerative medicine that may have applications with what we do. And the other thing that I think a lot of people don't know is they assume that when something comes out, it's going to be well studied, released by who knows what, an academic university center, large studies, big medical journals. In fact, we're kind of in an orphan field. So really high quality research is not being done at academic medical centers on how to make hair transplantation better. Right. And so what I've always felt is it's really up to us, it's up to me, and even though I can't do those kind of studies that they might do at a large academic center, I can do observation, then I can share with my peers, we can interact, we can talk about ways to make it better. I mean, that's how the post-op AT spray came about. We didn't do a large study, but to our observation, it clearly improved results. Other doctors began adopting it, almost uniformly. They found it improved their results. That's how our field has evolved.
Right.
You know, the same way with surgical techniques, there wasn't large studies. It was one person sort of pioneered a change, and then other people started copying it, making that better, and it led to something else. And you know, that's what I'm interested in continuing to do, is taking these things from the scientific research realm, bringing them into the clinic, you know, trying to improve outcomes.
Right.
What I would say about the resistance to change is that when people get comfortable doing things a certain way, there's always going to be a resistance to change. For example, when Dr. Limmer first started talking about using microscopes, well, this immediately added to the complexity of the procedure. Instead of doing a hair transplant with 1 or 2 assistants, now you needed a team of assistants who were trained to look under microscopes to trim the grafts.
Right.
So the big resistance there was, you know, not only the surgeon gaining the skills, but hiring, training staff to do all that.
Investing in the microscope.
Investing
bigger space, maybe.
Bigger space, longer, you know, you can't, you know, in the old days, a doctor might do 5 or 6 hair transplants in a day, you know, in the plug days. And so, you know, doing 1 case a day obviously was a major radical change. In terms of, for example, switching to FUE, you know, I think it's totally different mindset. It's a paradigm shift, and I think if you look back really in all areas of medicine, there's resistance to change, and then there's sort of a sudden leap, and then all of a sudden everyone's doing it and says, yeah, that's the way we've always done it. You know, that's sort of the natural evolution. And then it stays like that for a while, and someone pushes the boundaries and everyone says they're crazy, and until they're proven right, and then everyone, of course, copies it and says, yeah, that's the way we always have done it. So it was very slow, and it was even slower than adopting the follicular unit technique. When FUE was first presented, at least to me, when I was first exposed to it in 2002 in Chicago by Dr. Assman, it seemed very interesting, but it was just, it didn't seem like something that would be practical anytime soon to me. I immediately started trying it, and I didn't feel like I was very good at it. I didn't feel like I got good grafts compared to what we got with follicular unit strip surgery. It really wasn't until around, I would say, 2010 that I started routinely seeing results from other clinics that I thought were impressive, and the light bulb finally went on and said, wow, they can really produce results comparable to strip surgery. That was the turning point in my mind when I saw, and in fact, it wasn't just pictures on the internet, it was patients presented at work, at conferences, where I said, wow, I mean, this is as good as strip surgery. And by that point, other doctors were doing it. So I wasn't by any means an early adopter, but I wasn't as late as, you know, some people were either. So I really started jumping into it more in 2010. I probably would have done more if I had felt like there was more demand. Now, as I've done more, it just seems like those patients have come to me. So, you know, our numbers have increased in doing FUE because I am seeing more men willing to shave. But I still see a good number of men who expect to take a week off, not shave, and it's just not practical to do 3,000 FUE without shaving and have the patient get back to work in a week without much detectability. And also I do a fair amount of women, and they obviously do not want to shave, and so to give them what I think they need, usually around 2,000 grafts or so, it just lends itself to strip. So in my practice right now, strip and FUE coexist very happily. I see a patient who I think is a great candidate for FUE, and we talk about that. Or I see someone who's great for strip, we talk about that. And then there's people who can line up the pros and cons of each, and they're in between and they can decide. I really enjoy it. I feel like I'm very good at it. I feel like I can get good grafts. And And I feel like my results with FUE now are just as good as my results with strip. So that's, for me, a huge milestone. And I'm not bragging, I'm just saying, for me, I had to, it took me a while to get to that point. If anything, it took me a very long time with FUE. I mean, if you think of it, from the first time I started trying FUE after I got back from Chicago in 2002 to this point in time, 10 years to get really comfortable with a technique, that's a long time. It just seems, certainly in the last 20 years, men are wearing their hair shorter.
Yeah.
I know when I trained 20 years ago, the donor scar just wasn't even on my radar. Like, who cares? Guys wear their hair long enough to cover it. Yeah. And it seems like hair's, and then, you create a visible scar in someone who wears their hair short enough to see it. I mean, that, to me, I'm really bothered by anything less than perfect. Mm-hmm. So, if I've created a scar that's visible, that really bothers me. Huge, obviously, yeah, huge. Not only in, publicizing bad scars, which certainly I think maybe unfairly scared a lot of guys into FUE, but mainly in publicizing the great results that a lot of the FUE pioneers were getting.
Right.
Yeah, honestly, I don't care who developed it, I don't care who thought of it.
Yeah. If
there's a good idea out there, whether it's a technique, whether it's a treatment that's going to benefit my patients, I want it.
Yeah.
I want to be able to offer it to patients who come to see me.
Very good. All right. Well, thanks for the question and answer session, and thanks for having me at your clinic. And
enjoyed it.
Yeah.
Thanks, Joe.
Awesome.